Welcome to PEM Chat. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Tony Dobson. I am a family and emergency nurse practitioner in Chattanooga, Tennessee, and I will be your host. Welcome, everybody, to another episode of PEM Chat. I am very fortunate to be here today with Jen Stanfield. Hi, Jen.
Hello.
Yay, welcome. We're going to be talking about childhood physical abuse today, or NAT. We like to use that the abbreviation for non-accidental trauma, but if that's not something you're familiar with, what we're going to be talking about is child abuse. This is going to be a two-part series. We're going to talk about physical child abuse today, and then we're going to talk about sexual abuse on a subsequent podcast. But today we're going to do the physical abuse section. So this is your trigger warning. If you do not want to listen to this podcast because this upsets you or bothers you, this is your opportunity not to listen. But I do encourage you that if you are a provider and you are providing care for children, this is absolutely something you need to know about. This is something we all need to know about because you're going to encounter this in your career. So I encourage you to stay because Jen is a wealth of information. She's been doing this a long time, has a lot of experience. And we're going to talk about all that today. So Jen, tell me a little bit about you, who you are and what you do.
Well, I'm Jen Stanfield. I'm a PA in the Children's Hospital ER, where I have been working for 21 years. My kids were babies when I started. Now they are grown adults about to be finished with college. And I have stuck through the years of working at Children's ER because the team we have is amazing, the hospital is amazing, and I absolutely love taking care of kids.
Yes, I'm so blessed that I get to work with you. It's really, truly an honor. So child abuse. I looked up a few statistics today to kind of introduce this topic. As of 2022, 3 million reported cases of child abuse in the United States, 500,000 of which were confirmed cases of child abuse. 67% of those were victimized by a parent or legal guardian. And there were 1,990 children that died as a result of child abuse in 2022. Tell me how much we see here at Children's.
We see over 600 cases a year of all types of child abuse. I track physical abuse, neglect, child sex abuse, sexual assault, exposure to domestic violence, drug exposure, different kinds of social dysfunction, psychological abuse, medical neglect, human trafficking, and Munchausen syndrome.
Yeah, that's a lot. Who's most at risk?
Well, any child who is not of the age to enter school yet, under 4, is most at risk. They do not have the watchful eyes of a teacher as an added part of their safety net to make report. Teachers make about a third of reports to the child abuse hotline, and kids under 4 haven't entered that system yet. They're also at home with a parent all day who may or may not have outlets appropriate to raising healthy kids in a healthy environment.
This is why it takes a village.
It does. It absolutely does. And kids under the age of 1 are the most at risk. They are the most at risk for dying from their injuries and the most at risk for experiencing severe physical child abuse and neglect.
So let's talk about that most at-risk age group and what do those injuries look like?
Okay. Well, injuries that are indicative of child abuse aren't always the severe injuries that you were probably thinking of. Although a child is most likely to die from abusive head trauma and second most likely to die of blunt abdominal trauma, they usually start out with what we call a sentinel injury. And that would be a seemingly small injury noted on the child's physical exam that is the precursor to a more dangerous injury to come. In other words, the child who dies of a shaking incident or is devastated by a shaking incident usually starts out with a minor injury noted in a physical exam somewhere in the child's medical chart at a walk-in clinic, a pediatric office, or a hospital that didn't seem to be that dangerous, but was the precursor to a more dangerous injury. Sentinel injuries have been well researched by many teams. The most common paper cited is Sheets et al., which came out more than 10 years ago and looked at 400 hospitalized children with injuries. They divided those children into 3 categories. 1, obviously injured by accident, say from the scene of a car accident. 2, at moderate risk. And 3, at most likely risk of child abuse. And what they found after looking in the charts of these children is that none of the accidentally injured children had sentinel injuries documented in their charts. A small amount, around 8%, had injuries documented in their charts of the moderate risk child abuse. And of those injured almost certainly by child abuse, about 27% had injuries documented in their chart somewhere prior to the devastating injury. What that means is if you act on sentinel injuries found, you potentially could prevent the devastating injury to come. So we can talk about what sentinel injuries are, what you're looking for.
Yeah, we actually have like a really handy mnemonic to help us identify these injuries. Walk us through what that looks like.
Okay, we have this mnemonic thanks to the careful work of Mary Clyde Pierce. It is called TEN4 FACES-P. The first part of that mnemonic came out over 10 years ago, and it stands for torso, ears, and neck, TEN. The 4 has to do with the age of the child. What that means is any bruise under the age of 4 months that didn't come directly from the scene of a witnessed accident is high risk for child abuse. Any bruise, it doesn't matter where it is on the child's body. 4 months and under, all bruises get evaluated. Torso, ears, and neck under the age of 4 years, also high risk for child abuse. The ears in particular are the most at risk, so especially bilateral ear bruising, indicative of boxing or pinching, 90% of those kids have been abused. So very high risk for child abuse. We recommend that all children in this young preambulatory age group have a head-to-toe skin examination every time they're seen at a clinic, an urgent care, an ER, a hospital.
Yeah, such great advice because
Yes.
if you don't address them, you're never going to see these injuries,
You're
right?
not. And the reality is these babies do not present to children's emergency departments with the chief complaint of child abuse. They
Or a
come
bruise,
in with
yeah.
something else, like a cold
Yeah.
or a fever or crying or something else. And it's up to us to do a head-to-toe skin exam. And when we find these bruises, we have to investigate them. So, TEN4. Once Mary Clyde Pierce validated her study, she realized that it didn't catch enough sentinel injuries. So she added the next most common dangerous injuries to the preambulatory age group and added FACES-P. F for frenulum, the little piece of tissue that separates the upper lip from the gum. If you look at yourself in the mirror and lift your lips up, you'll see it right in the middle. Very dangerous for bottle shoving and pacifier shoving in a child who will not stop crying.
Yeah, and they usually come in, bleeding from the mouth?
Yes.
Yeah.
Even a history of blood in the mouth of a non-mobile baby is highly concerning for child abuse. So FACES-P. F is for frenulum. A is for auricle. Remember, the ears are the most concerning area for a child to bruise. C is the fatty part of the cheek. If you fall down the stairs and you hit your face, you're going to hit the bony prominences such as the zygoma or the forehead.
Mm-hmm.
You are not going to hit the fatty part of the cheek, which even in a baby who has fatty cheeks is going to indent, and you're not going to hit that part. E is for eyelid, another part that sort of indents. And so if you fall or hit your head, you're not going to hit the indented parts of your body. So eyelid bruising is highly concerning. S for subconjunctival hemorrhage, which should not be happening in non-mobile babies. And then P is for pattern. We don't like to see fingerprints. We don't like to see brands or burns, that kind of thing. Patterned bruises where you can tell the object that hit the child, such as a loop or a cord, that kind of thing. So any pattern is also considered a dangerous injury to a child. So the TEN4 and FACES-P rule are a really good way to start looking at sentinel injuries in kids, which could be indicative of a deeper injury that you can't see, which was not part of the child's history when they presented to your ER.
Yeah, so helpful. Before I worked at Children's, I didn't even know about this. I'm not sure I had ever heard of it. So, approaching this case without any guidance is really hard. How do I know what's okay and what's not? So this really gave me some really good guidance.
Absolutely. So it's good to know what is the evaluation. If you find a torso bruise in a 2-month-old whose chief complaint was thrush and a cold, what are you going to do? The family will almost always provide you with a story that very often involves a toddler sibling or a pet in the home as a mechanism for that bruise. The question is, what do you do now that you know that TEN4 and FACES-P injuries are high risk for child abuse?
So we've identified that we have a baby that has a TEN4 injury. What is the next step? How do we know what to do next?
So we refer to our physical abuse screening clinical practice guideline, which was established as a collaborative effort by all 5 children's hospitals in the state of Tennessee. It is not any different significantly from the same screening tools used in Atlanta, Seattle, Chicago, Baltimore, Philadelphia, Boston. All of us are using the same screening tools tailored to our specific hospital. They all involve using TEN4 and FACES-P, which is great because we want to standardize the approach to child abuse care in all babies, no matter where they're seen. So just like we would use a guideline to evaluate and treat asthma, bronchiolitis, pneumonia, sickle cell with fever, diabetic ketoacidosis, we approach injuries in babies using the same guideline, the same time, every time, so that we eliminate bias in how we approach these injuries in babies.
Yeah, that's great. And I will link that guideline. Of course, it's available if you Google it online, but I will link that in the show notes so that you can take a look at that guideline. So let's just kind of run through like a case so we can talk about what's some of the things on the guideline are. Let's say we have a baby with a bruise on its cheek.
Okay. Let's say you have a 6-week-old who comes in for evaluation of fever, and while you're doing your examination, you see a purple bruise in the fatty part of the cheek. Hopefully, you have stripped the baby down and looked head to toe for any other skin findings, scars, previous injuries, other bruises. Always look at the frenulum. And because the fatty part of the cheek is part of the FACES-P screen, in a 6-week-old, it's a high-risk injury for child abuse. So we launch a kind of medical investigation into what deeper injuries may be associated with this seemingly minor injury. That includes lab work, which includes liver functions and a lipase, a CBC. If there's significant bruising, we will add coags. We also do what we call a skeletal survey, and that is 20-something pictures, depending on your hospital, of all bones in the body with specific views to account for the difficulty finding rib fractures. We also, in most babies with TEN4 FACES-P findings, frenulum injuries, perineal injuries, burns in little tiny infants, we also include a head CT.
So if you don't see specific trauma to the head, when you're going to add a head CT anyway, just because of the age?
Depending on how risky the injury is, if I have a 6-week-old with a positive TEN4 FACES-P screen, yes, I am probably going to add a head CT with a 3D reconstruction of the skull.
What if I'm working in like a community facility and we don't do pediatrics? Like we don't have, we're not used to doing pediatric x-rays or pediatric CTs. What guidance would you give us?
Well, we also have a guideline written for non-pediatric facilities that outlines the same risk factors and the same evaluation. When you find these findings, the first thing you do is call your friendly local children's hospital ER or child abuse team on call and find out what to do next. Depending on the risk of the injury, we may or may not transfer immediately for imaging and labs. We may be able to secure outpatient follow-up within 24 hours. But the truth is, the younger the baby with the findings that we've just discussed, most of those will need to be transferred to a pediatric facility for the skeletal survey, the labs, and the head CT.
So we've decided to do some additional testing on this baby. We get the labs back. What are we looking for? What's going to cue us in that we've got some sort of massive underlying injury we need to be more concerned about?
Okay, so This might be a shocking statistic, but in my personal experience, if I have a true TEN4 FACES-P finding in an infant, it is unusual to not find a deeper injury as part of the workup. For example, the very first time I applied the bruising clinical decision rule in a baby who had a torso bruise, I found rib fractures, metaphyseal fractures, and elevated liver functions. If the AST or the ALT are higher than 80, or if the lipase is higher than 100, we do advanced imaging of the abdomen pelvis. And I will tell you that the very first time I applied this rule, I found a liver laceration.
Wow.
This child's chief complaint was a cold. I found a bruise. I followed the guideline. I found a liver laceration and multiple broken bones.
Yeah, scary. Makes you kind of wonder what we're missing if we're not looking.
Exactly, because these babies can't tell you what happened at home. What do we do?
Okay, so our kids' labs come back abnormal. Let's say our liver enzymes are up and we have to do a CT of the abdomen and we find something. What do we do with this kid next?
Well, already you had a high-risk injury with a positive TEN4 FACES-P screen. So already you were going to need to call the Department of Children's Services for your state to alert them that you have an injury that is high risk for child abuse. Now you have found even more dangerous injuries. If you have a liver laceration, a splenic laceration, a renal injury, or anything else intra-abdominally that's suggestive of injury, you now have an injury that needs to be admitted to the hospital. Even if you have an injury such as rib fractures that are already healing, you have high-risk injuries for child abuse, which you can't safety plan from an ER. So those babies get admitted to the hospital.
So we have to call DCS.
We do.
How do I approach this with this family? Give me some scripting. This is tough. I feel like everybody really struggles with this. And I've even gone to lectures where people advise that you should lie to the family and hide this from them. So give us some scripting.
No. If for no other reason, we don't want to lose trust with these families. We really truly have the best interest of the child's safety at heart. That is why we're doing this in the first place. So we absolutely, through every stage of this evaluation, have to build trust with families. It's good to remember that many times the parents in the room, although they may be perpetrators, were at one point victims. This is generational abuse, and we must treat them like humans. And so I tell parents that if I find an appendicitis in a child, I call surgery. If I have a newly diagnosed diabetic, I call endocrine service. In this case, I have an injury to a child that I can't fully explain. I call the social work team for the state of Tennessee. And in some cases, I think the child is a little bit more at risk by their more dangerous injuries. I have to bring them into the hospital until we can figure out what else to do for this baby. I do it the same way every time, no matter what. It eliminates bias, and it also helps prevent me from missing dangerous injuries in kids while we figure out what to do with this baby.
Do you ever say these findings are concerning for child abuse?
I don't necessarily use the word child abuse, but I do say that these injuries are not consistent with an accident.
What if we're concerned they're going to run out the door with the baby?
We do invite parents the chance to stay with their children. We encourage it. We want to have them stay. We do say that the child absolutely cannot leave the hospital while we are doing this evaluation for the safety of the child. The parent may need to go figure out what to do about their other children. They may need to be at work. They may have all kinds of reasons they need to leave the hospital. We don't prevent parents from leaving the hospital. They just can't leave without their child until the social workers from the state come and tell us that that's an appropriate plan.
If I was working at a community facility and I was planning to transfer this patient, say I found injuries like we just ran through, and I'm going to transfer this patient from an outside facility, say to our children's ER, what do you tell the families?
Well, first of all, those kids must come by ambulance, because as great a rapport as you think you have with a family who says they promise to drive them to Children's Hospital once they leave your facility, you are putting great trust in a fragile system. And more often than not, they don't come, or they say they'll come tomorrow, or they suddenly realize they were out of gas, or that their car can't make it 50 miles to Children's. So these kids have to come by ambulance. They don't have to come sirens running, but they do have to come by ambulance to ensure safe transport and timely transport.
Yeah. And do you still tell that family, like, that, we're concerned for your child's safety. We don't know what happened. We need to transfer there because
Absolutely.
there needs to be further investigation?
Yes. You can say truthfully that your community hospital are not experts in baby injuries. And so you need to send them to the experts in infant injuries for a closer look to make sure you're not missing anything more dangerous, because this particular bruise may look very harmless, but because of where it is and the age of your child, it may show that there is a deeper injury in your baby that can only be determined at a children's hospital in a timely way.
So that particular baby that we've been talking about gets admitted. We've called DCS. Do we need to call the police?
In severe physical abuse cases, the police will be called by our hospital social work team, yes. I do not think that is necessarily a provider decision. I think that falls under the responsibility of social work team. But we are a team and we work together. And in severe physical abuse cases, which most TEN4 injuries end up becoming, the police are involved.
Okay. So we talked about the non-ambulatory group. Are we going to segue to this more ambulatory group?
Yes. So, let's back up just a little bit. When we're evaluating any injury in any child, the minute you think that you don't have a clear history of how a bruise or an injury occurred, it's a great time to take a step back, review your general pediatrics knowledge, and take a developmental history. It sounds like it will take a long time, but it actually doesn't. And sometimes I'll just do this while I'm examining the baby or the young child. I will ask, is your baby rolling over front to back, which we know happens around 4 months? Is your baby rolling back to front? Can they sit without support? Can they crawl? And it's good to know that crawlers happen usually between 7 and 10 months. Kids walk between 12 and 15 months, and it's not considered a delay until closer to 18 months. So if somebody says, yeah, my baby learned to walk at age 9 months, I usually try to watch them walk in the ER room so I can kind of say, oh, this kid's very mobile. They're climbing all over the bed. They absolutely could have caused this injury. But it becomes gray because babies develop at different rates. And some are a little behind and some are a little bit ahead. And it's good to know, what can this baby do with regard to causing his or her own injuries?
Mm-hmm.
So developmental history is absolutely key, and it takes some of the gray areas of injury evaluation once babies become more ambulatory.
I love that, because if they're telling you the kid was sitting up and doing something, but they can't do that, that doesn't make sense.
Yes, absolutely. For example, how does a 3-month-old roll off the middle of a king-size bed when they're not old enough to roll over one way, much less both?
Yeah, that makes sense. Okay, great. So this protocol is kind of divided into 2 sections with our non-ambulatory and then our more ambulatory kids. What would this look like if we're dealing with a more ambulatory child?
Right. So the American Academy of Pediatrics recommends that skeletal survey for all kids under the age of 2 with suspected physical abuse. Suspected is the key word. You do not have to prove that abuse is taking place. You just have to suspect it. And if you believe, because they have a positive TEN4 screen, or they have an unexplained injury, or they had a delay in seeking care, or the bruises appear to be of different age, then you have concerns for child abuse. It is good to get a skeletal survey under the age of 2. We also continue with the same screening labs as kids become more mobile and older, because remember, TEN4 isn't just about the under 4 months crowd. It's also for kids under the age of 4. So if you have a 2-year-old with bilateral ear bruising, you have high concerns that the child has been abused, you're still going to launch some of the same labs. You may not need to get the liver labs, but you might want to go ahead and get a CBC and coags. If they just hit 2, a skeletal survey is still indicated. That injury is still very high risk for child abuse, so you still involve the state social work team.
Do you ever consider a head CT on that kid?
Yes, CTs are very indicated in ambulatory kids if they have significant facial bruising, abnormal neurological examination, vomiting, irritability, seizure-like activity, lethargy, any kind of decrease in muscle tone, respiratory impairment, altered mental status. Brain imaging is absolutely indicated.
So we have this 4-year-old kid with bilateral ear injuries. We have gotten the labs. We considered a head CT. And let's say we didn't find anything.
Right. So a 4-year-old does not need a skeletal survey. They are old enough to tell you what happened, so the history becomes critical because they can talk. And they are outside that under 2 window. Now, there is a caveat. You can do a skeletal survey between 2 and 3 years old if a child is severely injured. Certainly if a child is developmentally delayed and cannot tell you what happened, or developmentally delayed chronic person who's more at risk for child abuse, you might end up getting a skeletal survey up to the age of 3. But after that, children should be able to tell you what happened, and you can get by the history what may have happened, so you know you don't need 25 x-rays of that person's ribs if they can tell you that someone just pinched their ears.
Let's talk a little bit about how you collect a history on these kids. Let's say you went in the room, you examine this patient, they're here for a cold. You see these ear injuries that we've been talking about. You are kind of changing gears and you're on this NAT pathway in your head, and you know you need to do a little bit more with regard to history taking. Where do you go from there?
It is a great idea if you have a child over 3 to interview the child without the parent. Some parents are very amenable to this. Some parents are very defensive and they realize what you're doing immediately and they do not allow it. I try to do different techniques. Sometimes if I'm doing x-rays, I'll go down to the radiology department and I will go into the x-ray room with the child while the parent's out in the hallway. Sometimes I say, can your child come help pick out a popsicle or a prize? And while I'm allowing them to choose the flavor of popsicle, I can say, what happened to your ear? Sometimes I have to be a little bit more authoritative about it and say, this is what we're going to do. I would like for you to step out and I'm going to just chat with your child about the injury. And then I'm going to flip-flop and I would like to talk to you about the injury. So you both have a chance to talk about it. It helps to know what you're doing and be comfortable doing this because it can get quite uncomfortable, but you still have to do it, even if there's a little bit of pushback from the family.
Yeah. What was the Ambrose book that you had me read? The
David Ambrose.
So good.
A Place Called Home. I think
So
it should
good.
be required reading for anyone who works with children. And to that end, I also think The Body Keeps the Score. It should also be required reading, which goes over the effects of childhood trauma.
Yeah, he talks in that book about how many opportunities were missed in his childhood because every time someone interviewed, his parent was present. And he could not share, and he wanted to, and eventually he got old enough, and he finally disclosed. But you know, you're not going to get these kids to be real forthright if you're interviewing them with their perpetrator sitting next to them.
Right, and that goes for, do you have food in the house? One social worker came to his house and asked the mom, and she said they have plenty of food, and he the whole time was thinking in his head, if you open the refrigerator door, you will see that it is empty. But no one did, and no one asked.
Yeah.
So.
Wonderful book. Everyone should read it. Okay, so we have a kid, 4 years old, has these TEN4 injuries. We do these extra labs, and they don't have any abnormal findings. Where do we go from there?
So a couple of things. One is we have had EPIC since 2017. And so for most kids, we can go back in the EPIC history and see if they have presented to our department for previous injuries. You can go looking for sentinel injuries yourself. 2, we can interview the child. 3, we can refer to our guidelines that say what are the most at-risk injuries for these children. And if the injury is not explained by the trauma history or medical condition, if the trauma history is not consistent with the child's developmental capabilities, if there was a significant delay in seeking care, or if the injuries are just so high risk that they warrant investigation, you should call child abuse services for your state. I think ear bruising, neck bruising, torso injuries, however minor they seem to you, warrant a child abuse investigation. So I call DCS for every single one of those. It's a great idea to take a domestic violence history. If there's domestic violence in the home, those kids are super at risk. If those kids under the age of 2 are involved in a domestic dispute, they too need a bone survey.
Okay. I'm not sure I've always thought about that. Thank you. Okay. So how do we decide with these kids who has to be admitted, who can go home?
It depends on your safety plan. Sometimes you know from the history that the child was picked up after a weekend with a family member and they come running into the ER. I just picked my kid up. Look, this bruising is terrible. Please look at this. You have a seemingly appropriate caregiver. You could probably safety plan that kid home if the evaluation is otherwise negative. If you find additional fractures and you start having a longer list of injuries of concern, it's reasonable to admit to the hospital until DCS can come out, interview all family members, make home visits as indicated, and determine who is going to be the safe parent to take that child home. Another safety net for these kids with regard to the evaluation is the follow-up bone survey, which is recommended in kids 14 to 21 days after the initial skeletal survey is done. Even if the initial skeletal survey done was negative, if you have high-risk injuries, a follow-up skeletal survey should be done, and DCS should keep the case open until that survey is done, because things like rib fractures are very difficult to spot in the acute phase and very easy in the healing phase, and you will very often find rib fractures in the healing phase that were missed on the initial.
Yeah, it's just like when we deal with an orthopedic injury in a kid. We have a negative image, but they still have all this point tenderness and they can't range their arm. Like, we don't just send them home and say it's negative. We splint them and we send them to ortho and they reimage it in a week and you see remodeling of the bone. I think it's the same idea. We just need to remember that when we're dealing with these little bitty babies.
Right.
Where do you send them to do that?
So we have a child abuse clinic on Wednesdays, and DCS is involved. Between the child abuse clinic and DCS, the appointment is set up for 2 to 3 Wednesdays out from the initial visit, and they go in for their evaluation. And then care coordination is arranged following that, depending on what they find. Sometimes they close the case. Sometimes the injury, for example, very often a skull fracture with no intracranial bleed that is linear, non-depressed, appropriate story, is determined to be an accident. You don't necessarily need a follow-up skeletal survey.
Can these kids ever follow up and do this through their pediatrician?
If the pediatrician is willing, the hospital will take an outpatient order for a follow-up skeletal survey, but fewer and fewer practices in town are willing to take this on. And so we rely heavily on a child abuse clinic to do this kind of follow-up.
If you're out at a local community hospital and you don't have access to this, probably a good idea to reach out to your children's hospital.
Yes, and that is what the non-pediatric facility guideline says. If you have a child outside the window of needing a bone survey, outside the window of needing a head CT, but you have an injury that's very concerning, start, if you can, with your child protection team from the children's hospital closest to you. If that is not available, you can call the ER and they will help direct. And sometimes outpatient coordination of care can be arranged without transferring to a children's hospital. Sometimes we can reassure you that an injury doesn't sound like abuse based on the history, the age of the child, and the injury found. And you can even let the child go without a child abuse investigation.
Yeah, I had that happen recently.
Mm-hmm.
It was, somebody called DCS on a dad and the kid had bruising on his shins that was appropriate for a 5-year-old, and the whole case was kind of silly, but we were able to do a really good skin exam and send him home.
Yeah.
Can we talk a little bit about the secondary trauma that we see with this? And for me, we all have cases where we know we've missed something. I think we're all very quick to be hard on ourselves. I have a case that comes directly into my mind when I think about this, and I didn't know enough to catch it. And in hindsight, when I learned, I was like, oh my God, I hope that kid's okay. Let's talk about that, because we all have cases like that, and we're all so hard on ourselves.
Yes, several things to say about that. The reason I got involved in advocating for child abuse victims at our hospital is when I arrived in 2003, there was nothing in place to protect the kids. There were no guidelines. There was no one on call. There was no pathway to follow to investigate injuries that were concerning. And I, too, let these kids go home because I had no knowledge and no one to call to ask for help. I still think about those kids every day. They stay with me. And I think once you learn the TEN4 FACES-P rule and some of the other high-risk injuries, you too are probably thinking, oh no, I missed an injury. We've all done it, and we have to move forward. I believe knowledge is power, and if you study this practice guideline and become familiar with it, and you follow the rules every time without exhibiting any bias, you will sleep better at night. If you still find yourself, like I do sometimes, waking up at 2:30 in the morning in a cold sweat, feeling like you might have missed a case, or maybe you just didn't say something right, or maybe your interaction with the parent was very tense and you just worry that you might have done something wrong, you're in really, really good company.
Mm-hmm.
Make friends with the providers at your local children's hospital. We are happy to help you debrief from these cases. Sometimes a retroactive plan can be put in place if it was a recent case. I personally have a lot of hobbies and a great social support system. 4 cats, a dog. I run every day.
A beautiful garden.
Yes. I'm crafty. And all of those things are things that I love doing, but they also help me process the secondary trauma syndrome. Because the reality is that even when everything goes well, you find the sentinel injury, you investigate it, your evaluation turns up more injuries, DCS gets involved, the safety plan goes well, and you feel like everybody did their job and everything went well, you still might find yourself at the stoplight crying 2 or 3 days later, as I have many times, and wonder what next. You absolutely must take care of yourself so that you can have the energy to come back tomorrow and take care of the next kid who needs you, so that we have no more David Ambroses in the world trying to process trauma as adults.
Amen. Couldn't have been said better.
Maybe could we spend just a few minutes talking about additional testing that happens in these babies? If you're not already mortified that we have shot 25 x-rays of a 3-month-old who started out with a bruise, once you find injuries that are consistent with shaking injuries or other high-risk injuries, the evaluation continues in hospital. So we should probably spend a few minutes talking about the shaken baby, now called abusive head trauma. Those babies can experience a constellation of findings which include retinal hemorrhages, subdural hemorrhages in the brain and spine, metaphyseal fractures, and rib fractures. Not all babies who are shaken have all 4 findings. Sometimes they have 1, 2, 3, or 4. But it is a constellation and a pattern that must be evaluated. What that means is, if you find rib fractures in a young baby, especially posterior rib fractures, we have concerns that the crying baby got shaken. So we have to go looking for other evidence of shaking. We have to employ the ophthalmologist on call to come do a retinal exam. We have to get an MRI because shaking is not often a single episode. A small shaking becomes a bigger shaking, becomes a more devastated shaking. And sometimes you need to get, all the time, you need to get an MRI brain and whole spine to find evidence of old and new subdural hemorrhages. Although those hemorrhages are not, most cases, surgical, they are great in the investigation part of the evaluation. They help to get confessions out of perpetrators, and they help to safety plan babies away from perpetrators. What is a metaphyseal fracture? When a baby won't stop crying, arms and legs are used as handles. You pick the baby up by the arms and legs. The very heavy part of the body, which is the head, falls back, which can cause subdural hemorrhages and retinal hemorrhages, but it can also shear off the weakest part of the long bone, which is called the metaphyseal area. Remember, these babies come out 20 inches long and they grow up to be 6'4". So they have a lot of growing to do in a short amount of time. That means bone is always turning over, which means the weak part of the bone, where the bone is growing, is at risk for twisting fractures. And the weak part of the bone shears off the shaft, causing a metaphyseal fracture. We call them bucket handle and corner fractures. And if you want to Google metaphyseal, corner, or bucket handle fracture, the images will come right up and you can see kind of what happens. These babies have been shaken. You will only find these if you get your bone survey, and you will only find retinal hemorrhages if you employ an ophthalmologist to do the exam. Sometimes the CT does not show the complete picture of how the brain has been shaken, but an MRI can distinguish old from new bleeds, and an MRI brain spine can also show additional hemorrhages in the thoracic and lumbar spine. So whole spine MRI is also recommended now with MRI brain.
Okay. You mentioned that crying babies kind of puts them at risk for abuse. What are some of the other things we need to be looking for?
Certainly. Any situation that prevents parent from bonding with child. We have a huge problem with incarceration rates in our country, which separates parents from their babies. And when they come home from being incarcerated, they have not had that opportunity to bond with the child. Prolonged NICU stays would be another great example of why parents don't have that opportunity to bond with their children from birth, and that is a setup for child abuse. Expectations of the parent. I think we all have an idea of what parenting is going to be like, and for most of us, we look forward to it. We bring the baby home, the baby won't stop crying for the first 6 months of his or her life, and it's exhausting. And sometimes it's just not the experience we hoped for or thought it would be. Sometimes we don't have social support to give a shout out for help when we're too exhausted to be a good parent. Sometimes we are suffering from the effects of domestic violence, the effects of substance abuse, untreated mental illness, our own childhood trauma. And those are all things that can prevent us from being great parents. And they are also huge risk factors for child abuse. Teen pregnancy, poverty, which would be the number one risk factor for child abuse.
Special needs babies?
Absolutely. Medically complex, developmentally delayed kids who just need extra care. And don't forget the siblings in the home who may, as a result, be neglected because the parent is using all of their energy to take care of the kid who is dependent on a G-tube and a trach.
Yeah. And sometimes it's just as simple as a crying baby. I'm going to use myself as an example. My oldest had colic, and I absolutely, at one point, remember putting him down and thinking, this is why people shake babies. Like, holy cow. And I set him down rather forcefully, and I said, I love you, and I am walking away. I was just done. 3 days of a screaming baby and no sleep. And it is just, it's tough. It's hard.
Yes. I tend to think I, in my own experience, could tolerate a nonstop crying for about 45 minutes. And by the time 60 minutes, I'm in tears. And thankfully, I have a great husband, and I had great neighbors at the time my kids were infants. I could call for help. I always had someone I could hand the baby to. But if you're at home alone, or if your extended family are addicted to drugs or fighting their own battles or not available, or you're scared if you hand the baby to one of them, they will be abusing your child, and you don't have those resources available, you are very much at risk for shaking your baby. And the peak incidence is around 2 months of age, but starting about 6 weeks to 4 months, when the baby's able to roll over and start to console themselves when they're uncomfortable, those babies are the most at risk for crying-related injuries.
All right.
I look at that, too, as an opportunity. How many times is crying the chief complaint in an ER or in a clinic? I can't get my baby to stop crying. I look at that as an opportunity to intervene before the abuse takes place, in addition to interviewing the parent and evaluating the child for possible injuries that may have already taken place.
Yeah, we see that all the time.
Yeah. Prevent if you can.
Great advice. All right, let's just kind of do a little recap, final thoughts, or maybe we'll just have a final thought. Anything else you want to add today, Jen?
Sure. I think of safety as a vital sign. You will never send a child home who is hypoxic or hypotensive. You'll never send a 3-week-old home with a fever of 100.5. You should not send kids home to unsafe environments. So you should plan, document, and execute a proper safety plan. And if you can't do that, the child needs to be admitted to the hospital until social work can come and do that for you. The other thing is, more than any other area of pediatrics, bias is a risk factor in the evaluation of child abuse. If your reason for not getting the skeletal survey, labs, or additional reporting evaluation is that they seem like a nice family, or they go to your church, or you can't imagine anyone would ever hurt their child, get the bone survey.
Yeah, absolutely. Yeah, it's hard. I think, but the more you employ the protocol, and just like you were saying, the more you make this rote and it's just you're on autopilot, I'm seeing these injuries, it fits this bill, I'm going to follow this protocol, the easier it is to avoid that.
And the easier it is to explain what you're doing to a parent. If your child had type 1 diabetes, I have this guideline. I'm going to order this fluid bolus. I'm going to order this insulin. I'm going to get these labs. And I'm going to do it the same way every time, so I don't risk the effects of an untreated diabetic ketoacidosis. Mm-hmm. You want me to do that for your child for any other physical injury or illness. I'm going to do it this way every time for this too. It's no different.
Yeah, I like it. Anything else?
I think that should do it.
Thank you for coming today. I appreciate you coming and talking to us about child abuse. You're such a wealth of information.
Thank you for having me.
Thanks for joining us today here at PEMChat. I hope you'll join us next month when Jennifer returns to complete this 2-part series. And our next episode is going to focus on child sexual abuse and sexual assault. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.